This is evidence-based clinical decision-making. Evidence-based clinical decision-making in this short lecture will define and identify evidence-based clinical decision-making components, describe steps in the evidence-based clinical decision-making process, and identify factors that influence our clinical decision-making. Evidence-based clinical decision-making can really be broken down into three components: the patient perspective, clinical experience, and evidence. The patient perspective you can think of as what that individual person's coming in with, both from the perspective of the disease they have, their viewpoints on that disease, on that viewpoints of treatment, and their cultural viewpoints on various things. Clinical experience, on the other hand, is made by years of experience from doctors seeing patients. This typically is done when a study can't be performed to meet all criteria to make an evidence-based decision. And the last criteria is evidence itself, both external and internal. External being from research studies from the literature, and internal being from evidence happening on the clinics and the patient's recovery from the disease as treatment is going on. The patient perspective itself can be broken down into a number of different characteristics, including some personal characteristics based upon their unique features of their eyes, as an example. Maybe their corneas are curved differently than somebody else's, as an example. They can have different views regarding treatment. They may not feel like the treatment is effective, or they're concerned about the actual side effects from the medication. They have different needs and expectations. Maybe taking a drop 2-3 times a day is too much for these patients in some situations. Maybe the drugs themselves are too expensive in some other situations. They have different tolerances and engagement with that treatment, though, that go back even to whether they can do 1 or 2 drops every single day. They'll also have cultural and linguistic characteristics and values and preferences that make each patient a unique perspective that has to be taken into account when we're making our clinical decisions. Evidence, which is obviously the most important parts of evidence-based practice, you can have two different main types of evidence: internal evidence and external evidence. Internal evidence really is involved in looking how the patient is progressing through treatment. Is it responding to treatment? As an example, we have a corneal ulcer. Maybe we put antibiotics on it. Is this corneal ulcer getting better or worse? Is evidence of our direction we're going and whether we need to maintain the course or change our decision-making. We also have patient data, which we can thought of as the visual acuity as an example of the same situation where the patient came in seeing 2400 on day 1. Is the clinical data getting better or worse? By day 30, this patient's getting better. They're at 2030. We're moving in the right direction. We also don't have external evidence that helps guide our treatment decision-making. The first of those three kind of criteria in external evidence are individual studies, systematic reviews, and evidence-based guidelines. Individual studies can think of as clinical trials and various studies done to guide our decision-making. This is kind of the first level of our decision-making when we look at the studies. Now, here's an example of a similar one for our ulcers, where this is a well-known study called Steroids for Corneal Ulcer Treatment trial, also known as SCUT. And it was a secondary 12-month clinical trial to decide whether steroids were good for treatment of a corneal ulcer. We can also, though, have systematic reviews. In this case, we have a meta-analysis of various types of treatment of NSAIDs for corneal pain, where we can not just look at one study and use its outcome, but look at all the studies that are out there on that topic and get a better idea of the true average and the true estimate of the treatment. And lastly, we have evidence-based guidelines. That's a consensus by a group of doctors, in this case optometrists. What do they say about eye care in these specific situations? An example of an evidence-based practice guideline is put out by the AOA, the American Optometric Association, every few years. This is one that specifically deals with eye care for patients with diabetes mellitus. But in there, it gives guidelines that have been developed over time, trying to incorporate individual studies, systematic reviews, and clinical experience from a panel of optometrists to decide what the best course of action is. Now, these, again, consensuses are then done by getting the majority opinion of a group of doctors, typically well-experienced, well in practice for 20, 30, 40 years. Now, all of our evidence, though, has a quality level to it. Here's a cutout from that same guideline we said before. This is the evidence levels that they use when they were making their decisions for that evidence-based guideline on diabetic eye care. You'll notice that different qualities of evidence exist. At the very top, we have the highest quality. At the bottom, we have the lowest quality. At that top is those meta-analyses, the systematic reviews, and randomized clinical trials. Now, depending on the design of the randomized clinical trial, it could be at different levels of grades from A to B. As we go to grade B, we have then randomized clinical trials that are of weaker designs. Maybe they've created some poor decisions as far as the study design goes. You can also have some diagnostic studies that deal in narrower populations. They usually have samples that do not reflect the population as a whole. They sometimes use poor reference standards, and the comparison between the test and the reference standard is not necessarily blinded. After that, we have case control studies where two patients, one a case and one control, are matched up typically by things like age or some other important factor involved in the disease. This is, in this situation, a grade C level evidence and strength. And lastly, the lowest quality are things like case reports and stuff like that. Now you notice that they go from highest again to lowest quality, A being at the top, with a systematic review, which makes sense. A meta-analysis or a systematic review is a way to actually analyze an average across a large results of studies. That means it has more subjects, more evidence suggesting what's the true guidelines for treatment is compared to just a single clinical trial. Now, what is a meta-analysis as we talk about it? By definition, a meta-analysis is a statistical technique that combines results from multiple independent studies to obtain a more robust estimate of treatment's effects. When we look at this worldwide prevalence of open-angle glaucoma on the right here from a systematic review, is the prevalence looking across all these studies? In some studies, it's 0% or approaching 0%. And in some other populations, it's closer to 7%, which is the true actual percentage of prevalence worldwide for glaucoma. Well, if we take all the studies combined and we average them through different techniques of meta-analysis or systematic reviews, we can get the true or best estimate of the worldwide prevalence to be actually about 1 to 2%. Now, meta-analyses provide different strengths and weaknesses. They have some limitations. The strengths, though, are they provide that comprehensive overview by pooling data from various studies. This allows for increased statistical power due to the larger sample sizes and allows for assessment of consistency across different studies. Its limitations, though, can depend on the quality of the individual studies included, the heterogeneity among the studies as a result of that. Maybe that the study populations or the studies, the way they were conducted, are so different they shouldn't be actually pooled together for some reason. We also have some publication bias that may influence that. What is publication bias? That's when somebody gets a result that isn't statistically significant. It's unlikely to be published. Because of that, negative studies or null studies don't get added into the average, so the estimate can be a little bit over-exaggerated, a little larger than the true effect size. In something like this, where it's prevalence, that's not so much of a problem. It is a problem when you're looking at two, say, drug interactions where we're seeing the effect of the drug. If multiple studies had found no effect, they probably didn't get published, but that one or two that did find effect did get published. And so the effect size can be affected by that publication bias. Now, this is typically, though, still means that meta-analyses and systematic reviews have the highest level of evidence when we're thinking about evidence-based decision-making. The next highest level of evidence-based decision-making is randomized clinical trials. Randomized clinical trials are experimental studies where participants are randomly assigned into two different interventions or control groups. And these strengths have a lot of different advantages to them. They allow for randomization, which minimizes some of the biases that can occur. They can allow for causal and interference. They can allow for them for rigorous study designs. But some of the limitations are they are resource intensive and time consuming. That means they take millions and millions of dollars and oftentimes 2, 3, 4, 5 years. Because of that, they're not always feasible for every single statistical or research question we have out there. And so we can't always rely on randomized clinical trials if it's just not feasible. This is the second highest typically level of evidence. It's a moderate level where especially when it's well designed. It can have a low level, though, of evidence if it's methodologically flawed. Here's an example of a clinical trial, the ocular hypertensive treatment study, OATS, which is another study we'll talk about as the semester goes on. It was a randomized trial determining the topical ocular hypertensive medications, whether treatment or delaying treatment had any effect on the onset and progression of primary open-angle glaucoma. The next up, or the next highest level, is controlled trials. These are trials that lack randomization but still compare interventions within a group. Its strengths, though, are practical and randomization is challenging. It also provides valuable information. Its limitations, though, are it's prone to selection bias. And causality is very hard to establish in these situations. This level of evidence can be moderate to low, depending on the quality of the design of the study. After that, case control studies. These are studies comparing individuals with specific outcomes to those without outcomes. So you find somebody with a disease and another person without the disease, and you just compare those two individuals. Again, usually aligning by age, so you'll have two people who are 44 years old, two people who are 88 years old in the study. These are really useful for rare diseases or rare outcomes. It is very challenging to do a clinical trial, randomized trial on something that's rare. It's impossible to find enough patients to do that study, especially when time's another factor of that. This allows it to be efficient for studying associations. Its limitations, though, is it's oftentimes retrospectively designed. The patients that with the disease are retrospective, and then typically you go out and find a case control that matches that person. It can also be very vulnerable to recall bias. Due to this, it has a low level of evidence. And lastly, but not least, is case reports. Case reports and case series are just case reports that describe individual patients' experiences, while case series present data on a group of patients with similar conditions. It's kind of mostly when a doctor sits around and says, hey, this one time I saw blank. Its strengths, though, is essential for pattern recognition, hypothesis generation, and it's good for documenting very rare or novel cases. Its limitations, though, are there's no control group, and it's prone to huge bias and confounding evidence. This is, again, for that reason, the lowest level of evidence when looking at whether something is efficacious for treatment and for clinical decision-making. Now, having said that, case reports are really where all this evidence starts. In the actual real world, we don't actually look for a study until we know there's a problem. And oftentimes that starts with a case report where the evidence started there and then moves its way up over time to more and more complex versions of studies where we have better evidence. So that doesn't mean case reports have no value. They're oftentimes there for the first time something is seen or some rare or unique or new findings. An example of that could be something like GPC, or giant papillary conjunctivitis. Someone first had to find GPC before we even had an idea to study it. So the first studies were coming out in the late 70s, early 80s on GPC. Here's one of the first studies by a team from Dr. Korb, Finmore, and Greiner. They were the first to report on the prevalence of GPC. Now, just because they saw GPC, it took somebody to see it first, and then finally we could study it to realize the dirty contact lenses and unclean lenses were the main problem that need to be treated, but that required clinical trials after that. Now, we've been talking about patient perspective and evidence. We haven't talked about clinical experience yet. Where does clinical experience come into play? Most situations with patients do not easily fit into a perfect situation. Just because there's a clinical study on X, Y, or Z doesn't mean it meets that patient's and that situation's exact fit into that problem. In this case, that's where clinical experience from the doctor's years and years of training and years of experience of seeing the patient needs to come into play to modify the factors in the treatment and decision-making for that individual patient. Sometimes evidence and patient needs can disagree. Sometimes secondary conditions can limit our options. If the patient has diabetes and something else, we then need to think about both diseases at the same time. There's really not a lot of clinical studies that do 2, 3, 4 diseases at the same time. It's very difficult to study. Also, as we discussed, many situations are just infeasible or ethically questionable to actually study. This is when clinical experience is then best used to set the course. An example of that could be, say, we have a patient that comes in for cataract evaluation and they really want to have a multifocal IOL. Well, evidence says the patients might be able to get to 20/20 at near and distance, but we know it's not going to be a great 20/20. This is where your experience would come into play. Do you recommend these multifocal patients to these patients? We do know that multifocal contact lenses are going to cause an enormous amount of glare, especially with headlights. They're going to decrease contrast overall and the quality of the image. So this is where we take into the clinical experience and the patient's actual situations and their needs into thought, into perspectives. So we could have 4 different patients all wanting multifocal contact lenses. This engineer up here who needs fine, high-tuned vision, they have a typical history of not really wanting their vision to be degraded in any quality whatsoever. They're probably a terrible person to have multifocal IOLs, and your clinical experience would say, no, please don't get a multifocal IOL. Similarly, a truck driver, especially a nighttime truck driver, a bus driver, something like that, you know they're going to experience some bad glare all the time. You probably wouldn't recommend that patient to have a multifocal IOL. On the other hand, you know, somebody who's been wearing multifocal contact lenses, they're used to that glare. They've been wearing them a long time. They probably are the best candidate for that multifocal IOL. And then there's other patients where they fit into a gray area and you're going to have to make a choice. As an example, a stay-at-home parent, who knows? It depends. Thank you.